Good afternoon, everyone. I want to go ahead and get started. For those of you who are joining us on Zoom, we welcome you. And we are very pleased to thank our partner and co-sponsor for these three sessions we've had yesterday and today, State Volunteer Mutual Insurance Company. It is a physician-owned insurance company, and the members actually own the company and have the right to vote for their board of directors who make decisions such as malpractice rates. They have brought us an excellent speaker, Dr. Rebecca Donald, who is a faculty member at Vanderbilt University. She's a member of their anesthesiology faculty and also pain management faculty. And that's how she splits her time in clinical practice. She has a great deal of expertise and very common sense, practical approaches to prescribing. So help me welcome Dr. Donald, and thank you so much for being here. Okay.
Thank you all. Okay, so we had some technical difficulties this morning. Hopefully we will not encounter those this afternoon, but if we do, we'll just roll with the punches. Thank you all for having me today. So today we're going to talk about maximizing patient safety while minimizing the risks of prescribing controlled substances. The video might play. Let's see. Nope, we've not had success with this one, but this was, the video was the public service announcement from the 1980s. This is your brain on drugs. Any questions? And that's essentially what my medical knowledge about drugs was until I kind of started working in pain management. And then it's evolved a little bit, and hopefully will help your understanding of substance use disorders and responsible opioid prescribing help that evolve today too. So we have several learning objectives today. We're going to expose you to concepts about the human craving brain and substance use disorders. We'll talk about the Tennessee chronic pain guidelines and discuss the CSMD, and then we'll use some case vignettes to talk about a few other things. So one of the things I want to highlight just to start off with is the fact that addiction is a disease. And unfortunately, it's the single most preventable cause of disability and death in the United States, given the numbers of patients who suffer from addictions of various sorts. It is inevitable that we will be taking care of these people. And it's really incumbent upon us to remember that addiction is in fact a disease, and we need to treat those patients with compassion, just as we treat patients who have other chronic medical conditions with compassion. C. Everett Koop, who is the former U.S. Surgeon General, said in 2003, addiction doesn't come heralded by a brass band. It sneaks up on you, and sometimes with extraordinary speed. And I think this is really true. People develop use disorders without even realizing that they're developing them. And then they find their lives completely destroyed. And they don't really know how to pick up the pieces without some help. So it is our job to try to prevent addiction from happening, but also to care for those patients when they do find themselves kind of in this desolate wasteland. We're going to go over the reward circuitry now. So our main, just as a review for everybody in case you don't deal with this in everyday life, our big player here is dopamine. So dopamine makes us feel good. So anytime we have a pleasurable experience of really any sort, the ventral tegmental area, which is located here in the midbrain, it releases dopamine, and that dopamine travels to multiple different areas of the brain. It travels to the amygdala, which is responsible for our emotional experience of things. It travels to the nucleus accumbens, which is responsible for not only motor function, but really the interface between motor function and the limbic system. And then it also travels to the prefrontal cortex, which is responsible for things like planning and giving us insight, but also judgment and empathy as well. And then finally, the ventral tegmental area sends dopamine to the hippocampus, which is located in the temporal lobe, not in the brainstem as it appears to be here. But the hippocampus is responsible for the formation of memories. Essentially, dopamine is released, travels to all these areas, and it tells us that these experiences are pleasurable. And just as a reminder, the amygdala, the hippocampus, The the nucleus accumbens and the cingulate gyrus make up the limbic system. And the limbic system is kind of our ancient reward system. It's where we feel pleasure, and it plays a role in emotion, reward, and memory. And so any disruptions in that limbic system are associated with things like anxiety or depression, and substance use disorders also play a role in the limbic system as well. So we're just going to take the example of chocolate cake. And I was informed this morning that chocolate cake is actually white cake with chocolate icing, not chocolate cake with chocolate icing. This would be devil's food cake. So we'll take the example of devil's food cake and see what happens here. So when you take a bite of cake, it is yummy. And your amygdala says, so your VTA releases dopamine. And then that dopamine travels to all these places on the left, your amygdala being one of them. So your amygdala says, gosh, that was amazing. That was delicious. I love this experience. I'm so happy because I'm eating chocolate cake. And then your hippocampus is like, well, gosh, let me remember this experience. It's been so amazing. I can't forget about it. So I want to know exactly what restaurant I'm in, who I'm with, what the cake was that I ordered, because I want to do it again. And then your nucleus accumbens, which is kind of that interplay between the limbic system and the motor function, says, well, let's take another bite. Let's just keep taking bites, and we're going to enjoy this ongoing pleasurable experience. The same thing essentially happens when you use any sort of substance of abuse. But unfortunately, when you're using drugs of abuse, there's a lot more dopamine than is a lot more dopamine released than would be naturally released from typical pleasurable things that we experience in life. So dopamine essentially overwhelms the system and basically hijacks the system into thinking, this is where we should live at baseline. We should be functioning with this level of dopamine all the time. But unfortunately, that's not the case, because it's just getting overloaded by these, the dopamine released from these drugs of abuse. When dopamine is released in excess because of these drugs, it means that our bodies actually end up not producing nearly the same quantity of dopamine that it did previously. So patients who use illicit substances or misuse substances end up actually having lower endogenous dopamine levels. And what that leads to is things like anhedonia, depression, anxiety. And so they function at a lower level. And so they're always seeking to get their dopamine levels higher. And this is what causes those cravings. People crave that release of dopamine over time. Because they crave such high levels of dopamine, they really feel compelled to use these substances over and over again, to the detriment of other things like seeking food, seeking water, seeking shelter, parenting responsibly, etc. All those other things that previously brought pleasure because they released dopamine are no longer releasing dopamine to the same degree. So people just want to, unfortunately, achieve the same levels of dopamine that are provided by these chemicals obtained in the substances of abuse. So just taking a look here, there are lots of different substances that are implicated in addiction, alcohol and opioids being two of the most prominent ones. But we also have process addictions, things like gambling, relationships, video games. Gaming disorder is now listed, has an ICD-11 code by the WHO. So really anything that kind of changes dopamine levels and changes how a person feels can be implicated in addiction. And just to review kind of what happens, we've gone over this, but compared to who they were before they started using opioids, people who have substance use disorders have reduced self-control. So that prefrontal cortex is no longer functioning in the same way that it did with insight and judgment. People are not able to make the rational decisions that they once were, and so they become very impulsive and compulsive. It's not a lack of self-will. These people would really much rather make rational decisions, make good decisions that are in their best interest. But unfortunately, they have such craving for a drug to achieve those dopamine levels that they're not able to make good decisions. I had a patient on Friday. I work in the opioid use disorder clinic, and she had used cocaine during the week prior. And I was trying to use some motivational interviewing to say, like, how can we troubleshoot this and come up with better ways to manage the situation when you are confronted with this temptation. And basically she said, well, I just need to say no. And I wanted to say, if it were that easy, you would not need to be in my clinic. Like if you could just say no, then wouldn't have a job. So I wish it were just as easy as saying no, but unfortunately that just actually doesn't work when you have a substance use disorder. Patients who have substance use disorders have increased anxiety and stress, poor control over their emotions. And then like I kind of alluded to, because of our memory involvement in addiction, certain situations, environments, being around certain friends will trigger the desire for use again. And so oftentimes people can't leave the environment that they're in because of various social circumstances. They can't get a new apartment or they can't get a new job. And so they're always going back to their environment that kind of triggers their use. And it's just a really vicious cycle. Tolerance develops. So over time, people require more and more opioid to achieve the same effect. And ultimately, they never get back to that initial high that they felt. They are always trying to achieve that high, but there's nothing as good as that very first high that they experience. And then again, because of the disruption of the dopaminergic pathways, things that were once pleasurable are now less pleasurable. So let's define substance use disorder or addiction. The National Institute on Drug Abuse defines addiction as a state in which an organism engages in a compulsive behavior. That behavior is reinforcing and the patient has loss of control and ability to limit their intake. The American Society of Addiction Medicine defines addiction as a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. It's characterized by impaired control, compulsive use, continued use despite harm, and then cravings. And then we often use the DSM-5 criteria to define opioid use disorder and make a diagnosis of opioid use disorder. I'm not going to read over all of these things here because you can read them, but just drawing your attention to the two at the very bottom here, exhibits withdrawal and exhibits tolerance. So I want to make sure everybody understands that tolerance and withdrawal are normal physiologic phenomenon that happen even if a person is using substances as prescribed to them. So if a person is taking opioids chronically, they will ultimately develop tolerance. Our bodies just get used to a drug and they require more and more over time to achieve the same effect, be it analgesic or otherwise. And if they're using those opioids chronically and then those are suddenly taken away from them, they will develop withdrawal symptoms. That just happens normally. So in order to meet the diagnostic criteria for opioid use disorder, because you can have mild opioid use disorder with just two of these symptoms. If you are taking medications as prescribed by a physician and you exhibit tolerance and withdrawal, that will not qualify as opioid use disorder. The patient must be using them inappropriately. So not as prescribed, taking more than prescribed, receiving them from somebody that is not a prescribing physician, et cetera. They have to be misusing the medicine in some way. If these 11 criteria are a little too much to remember, we can group them a little bit differently. So 4 categories include impaired control, social impairment, risky use, and pharmacologic impairment, the withdrawal intolerance that I talked about. And if that's still too much for you and alliteration works a little bit better, you can group things into compulsions, cravings, and consequences. So if patients have either of those 3, they will most likely qualify for the diagnosis of opioid use disorder. I want to take a minute here just to emphasize how important our language is. If statistically looking at patients with opioid use disorder, only about 10 to 20% of those with opioid use disorder receive treatment for their addiction. So, and one of the big reasons that people don't receive the treatment that they need is because of the stigma associated with it. People think that this is a moral failing. They're just not strong enough to beat their addiction. And we really want to change the way that that's viewed, especially in the medical community. So regardless of who you're talking to, whether it's a patient, a family member, or a colleague, we want to be really conscientious of our language and really focus on destigmatizing addiction. So we want to use person-first language, really emphasize the person who suffers from an addiction. So no longer wanting to use the term addict or abuser, certainly not junkie, but really refer to the patient as a person with substance use disorder, a patient with opioid use disorder. I will say that patients often refer to themselves as junkies or addicts, and that's okay. That's their own self-identification. I think a lot of that is rooted in shame as well, but we certainly don't want to perpetuate this ongoing stigma associated with these diseases. Other things that we want to be conscientious of are talking about urine drug screens. We don't refer to them as dirty or clean. We refer to them as being positive for a substance or negative for a substance, appropriately positive, inappropriately positive, et cetera. And then same thing for, we no longer talk about opioid substitution therapy or opioid replacement therapy. That implies that the patients are substituting one addiction for another, when in fact, that's not the case. These medications are used to treat the disorder, just as antihypertensives are used to treat high blood pressure. Medications for diabetes are used to treat the disease of diabetes. So we really want to focus on the medications to treat the disease, which is opioid use disorder. So now that we've talked a little bit about background and language, we want to learn about who is at greatest risk for developing opioid use disorder. Well, first off, say that anybody is at risk for developing opioid use disorder. It certainly doesn't discriminate, but there are certain things that put people at greater risk for developing opioid use disorder. So genetics plays a very large role. In fact, it's implicated in about 40 to 60% of the risk of addiction. And there's a pretty big interplay between genetics and environment. So it's thought that kind of this interplay between genetics and environment, and sorry, the pointer doesn't work. I tried to use it this morning and it caused everything to kind of crash. So I'm using the mouse here, but you can't see it, so I apologize. But genes and the environment play a role and are really coordinated with the initiation of substance use. And then if it progresses to a full-blown addiction, it may be more related to genetic factors. So genetic factors are more implicated in the ongoing use and the development of addiction. Second factor here are ACEs. What are ACEs? Well, they are adverse childhood experiences. There were 10 original ones from the original research, and these include things like physical, emotional, sexual abuse, physical or emotional neglect, and then household dysfunction, things like mental illness, having a relative that was incarcerated, having a mother who was treated violently, substance use in the house, and then divorce. And as you might imagine, the quantity of the traumatic events experienced in childhood really correlates with the development of addiction further in life. So the greater the number you have, the greater the risk of addiction. And as we have seen, as research into the ACEs has just kind of progressed over time, the ACEs are implicated not only in the development of substance use disorders, but also they are implicated in the development of a myriad of other chronic health conditions. So people who have experienced kind of extreme traumatic events in childhood, they live in states of chronic stress. So they have a lot of adrenaline and a lot of cortisol surging through their bodies. They're kind of living in a state of flight or fight. So increased levels of inflammation in their body. And this leads to disrupted normal neurodevelopment, which subsequently leads to social, emotional, and then cognitive impairment, along with like social factors and social determinants of health leads to things like the adoption of high-risk behaviors, which subsequently leads to disease, disability, and social problems, and then early death. So adverse childhood experience is really implicated in a lot of chronic medical conditions, addiction being one of them. So several of the medical conditions implicated in adverse childhood experiences, things like anxiety and depression. People who have a high ACEs score have higher use of antidepressants, diabetes, heart disease, COPD, adult smoking, obesity, suicide attempts, and then intimate partner violence as well. And just to give you a few numbers, if somebody has an ACEs score of 4 or 5, they're 7 times more likely to become a patient suffering from alcohol use disorder. And I will note here that I tried to change all of these slides to change the language, but I didn't get all of them. So you'll see some language on these slides that I would much prefer to have changed. So I'll try to draw your attention to those, but just keep in mind that some of the language is not the most appropriate. So people 7 times more likely to develop alcohol use disorder. Patients are 6 times more likely to have sex by the age of 15, 4 times more likely to have emphysema, and 2 times more likely to get cancer. And then if you have an ACEs score of 6 or greater, you are 30 times more likely to attempt suicide, and your lifespan is reduced by an average of 20 years. So pretty significant impacts on overall health. And then finally, the other thing that places somebody at risk for opioid use disorder is simply opioid exposure. You can't develop a use disorder if you're not exposed to it. So this is looking at a retrospective cohort study of opioid naive patients. Total number of over 560,000 patients, 56% of whom received postoperative opioids. This study found that the total duration of opioids that were used was the strongest predictor of misuse. So not necessarily the dose, but the duration of opioid use. And if a patient received a refill, it increased their risk of developing misuse by more than 40%. So refills have a pretty strong tie to developing opioid use disorder. Just looking at this graph, this is a compilation of data from 2006 to 2015, looking at opioid naive patients and the duration of their very first opioid prescription. So you can see that, and you've got 1-year probability of continuing opioids on the top, the solid line, and then the dotted line below that is the probability of continuing opioid use at 3 years. So if a patient's first opioid prescription was for 15 days, their probability of continuing opioid use at 1 year is greater than 25%. So 1 in 4 patients will continue to use opioids after 1 year. That drops to about 15% at 3 years. So 15% of those patients will continue to use opioids at 3 years, which is not insignificant. And I think this, plays a role in why the CDC implemented those guidelines back in 2016 to try to reduce the duration of prescriptions that patients receive. Taking a look at what happens to the brain to those with substance use disorder. So this is a PET scan, so it shows the brain activity. The top level is the normal control. So you see a lot of yellow activity, which indicates normal levels of activity, a little bit of red in there as well. The second line is that of a patient who was using cocaine, had cocaine use disorder, and then has been abstinent for 10 days. And what you see is that despite 10 days of abstinence, there's not a whole lot of normal brain activity there. You would expect to see a lot more yellow and red there with increasing normal brain activity, but there's a lot of blue there implicating that there's not a lot of normal brain activity. And then after 100 days of abstinence, you can see kind of the return of brain activity, but there's still pretty good absence of yellow and red there. So even after 100 days, the brain has not returned, 100 days of abstinence, the brain has not returned to normal activity. This is a PET scan of somebody who uses methamphetamines. Normal control here is on the left, and then somebody who has been abstaining for 1 month in the middle, and then 24 months of abstinence is here on the right. And what you see is that after 1 month of abstinence, you do have some brain activity, but it's certainly not at the levels of the normal control. And then at 24 months, really getting closer to normal, but you can see there's still some lack of activity there. So it's really thought it takes about 2 years of abstinence for the brain to recover. At this point, research is showing that brains may never recover to their prior level of functioning. And so, it makes it really hard for these people to get back to where they were previously. And one thing to remember is that when people use substances, their lives fall apart, and even they experience things like loss of job and loss of relationships. Their children may get taken away. And so there's a lot that goes into that as well. Things like depression, feelings of isolation, shame, et cetera. And so even if they recover their brain function completely, there's still a lot of pieces to pick up that can lead to a lot of other problems as well. Okay, so now we're going to turn to some clinical vignettes and use these as jumping off points for some other learning points. So for each vignette, we should think, is this good medicine or is it not? Is this an example of misprescribing, aberrant behavior, diversion, or addiction? What do I need to do in my do I need to change my practice to try to prevent this? And then just to give you a few definitions here, misprescribing is defined as prescribing controlled substances or controlled drugs in quantities or frequencies that are inappropriate for the patient's situation, their complaint, or their illness. Aberrant behaviors are behaviors that indicate misuse of a prescribed medication. And then addiction is continued use of a substance or process despite consequences. So our first vignette here, Mr. Mel A. Noma is a 68-year-old fair-skinned gentleman who sees his dermatologist for his annual visit. He's an otherwise healthy guy who takes a triptan every so often for his migraine headaches. And for the last 25 years, he's undergone skin biopsies every 2 to 3 years and has received a prescription after each procedure for oxycodone, Tylenol 500 with a total number of 15 pills dispensed. As a dutiful patient, he has refilled all of these prescriptions that has been written for him, but he's never actually taken any of the pain pills, and they've just collected in his medicine cabinet over time. So a few red flags might stand out to you. We'll go over them. Medications were just prescribed to him without any history taking, no questions about post-operative pain history, whether he's needed these medications in the past. They were just automatically written because a procedure was done. The patient received and filled the prescription that he's never needed in the past, so the patient didn't really think about whether he needed it or not. And then, unfortunately, in this vignette, the patient's granddaughter went into his medicine cabinet, took 140 of his opioid pills that were there, and then suffered from an unintentional overdose when she took the pills at a fishbowl party. And so yet again, this is an example of how we need to be conscientious about our clinical or our medication prescribing. So I want to draw your attention to this pie chart. This is a pie chart representing where people get their medications that when they misuse them. So I want to draw your attention to the right-hand side of the pie chart. So during the most recent episode of misuse, where did the patient receive, or where did the person receive that medication? So 50% of the people, all the gray there, 50% of those who misused a pain reliever bought it or were given it or took it from a friend or a relative. So 50% are getting it from a friend or a relative. And of that 50%, 80% of the friend or relative where they got it, that person was receiving the prescription from a single doctor. So doctors are prescribing things appropriately or what they think is appropriately, but then it's falling into the hands. So these are not people that are necessarily going doctor shopping, but the medication has the ability to fall into the wrong hands. So this just brings our attention to the fact that we really need to be conscientious about our opioid prescribing, be good stewards of opioids, and really think about the number of pills that we are putting into the community as a whole. Next clinical vignette. So it's Friday at 2 p.m. and Dr. Ray, who's a radiologist, asked Dr. Sapp to write a prescription for his pain. Dr. Ray has low back pain and is driving to Florida in the morning for a family vacation. And unfortunately, he can't get to his own doctor because of all the add-ons in the interventional radiology suite. Dr. Sapp therefore writes a prescription for hydrocodone Tylenol 7/325. The Dr. Ray is to take 1 to 3 times a day. A total number of pills dispensed is 18. And Dr. Sapp writes this prescription thinking that it's not going to hurt anyone. He's following the opioid prescribing rules of sticking to less than 3 days maximum and less than 180 morphine equivalents. So a few red flags here. Dr. Sapp did not query the CSMD to see what other prescriptions Dr. Ray may have received. He did not get a thorough history, and he did not do a physical exam. And I think most importantly, he didn't start with the more conservative therapies. And I think what's most important is that Dr. Sapp doesn't actually have a doctor-patient relationship with Dr. Ray, and so really not very responsible to prescribe to a friend. As a follow-up to this, in a heated argument over Dr. Ray's drug use, his wife calls the medical board. Apparently, Dr. Ray has been using hydrocodone for many months in increasing amounts and has become noticeably impaired. So during the Board of Medical Examiners investigation, they asked Dr. Sapp for Dr. Ray's chart. Of course, he doesn't have a chart to provide. And so Dr. Sapp spends over $23,000 on legal fees, only to have his medical license reprimanded, which is reported to the National Provider Database. And Dr. Ray was referred to the Physician Health Program. I want to take a minute here just to talk about the Physician Health Program. This is a program that is run by the state of Tennessee that is intended to help physicians who suffer from impairment due to mental health conditions or due to substance use disorder. It is a rehabilitative service. It's not meant to be punitive. So if you have, you or a colleague have substance use disorder of any sort, you can go to the Physician Health Program and get help. They will help you figure out ways to retain your medical license, get back into work, and they will follow up with you kind of long-term to make sure everything is going okay. So I just want to make sure everybody understands that it's a really great program that will keep everything confidential. Nothing is reported to the board. And it's a really great way to help doctors who are suffering so they don't have to suffer in isolation or in silence. There are multiple approaches to substance use disorder, keeping in mind that we always need to take a biopsychosocial approach to any addiction. Ideally, we would prevent substance use disorder in patients, but if not, it's important to have early recognition of the signs of substance use disorders, early identification that a disorder has developed, and then come up with treatment plans, relapse prevention plans. And then ultimately what we need as a society is things like policy and environmental change to make it easier to treat these patients and hopefully, prevent it for generations and future generations. Just to give you a few tools about screening and assessment. So screening is determining the possibility that a condition exists. So wanting to have our kind of senses heightened that there might be a problem that could develop in the future. And then assessment would be confirming the existence of a condition and its severity. So when thinking about screening for patients, we wanted to look at the things on the right-hand side of the screen and take a good history and document that history as well. Goals of screening. We want to make sure we identify both hazardous and harmful alcohol or drug use. We want to identify those patients who are at risk for aberrant behavior, and then those who are more likely to misuse substances in the future. There are lots of different types of screening tools. We'll go over some of here in a minute. Some of them are self-reported. Others can be administered by a clinician or even by a nurse. And then there are other ways of following up with patients to confirm whether they've been using substances or not. Things like breathalyzer, which checks blood alcohol levels. That's kind of the most common one that we do. But there are other ones like saliva, urine, hair, and nail testing. And then the PEth, which is for alcohol use as well. So several screening instruments here, and I'm not going to go over all the boxes. I'll just let you look at them. But the NIDA drug screening tool, NIDA drug use screening tool, CRAFT, which is car, relax, alone, forget, family, friends, and trouble. Audit, alcohol use disorders identification test, ORT, opioid risk tool, and then CAGE, which is originally for alcohol use, is cut down, annoyed, guilty, eye opener. So some of those are easy to remember. If you need to access any of these, they are at the links here. And then just to draw your attention to the CAGE aid, this one was previously, like I said, developed for alcohol to identify alcohol misuse. It's now been expanded to be able to identify other substances that are being misused. If a patient responds yes to one of these questions, this sensitivity of this test is 0.79, and then the specificity is 0.77. If a person answers yes to two or more of these responses, that sensitivity goes down slightly to 0.7, but the specificity increases to 0.85. And to look at the opioid risk tool or the ORT score, This is, meant to be given in the office. It's really quick to administer. 5 questions that really predict somebody's risk of developing aberrant behavior. It is gender specific, so males and females have different scoring levels, and basically looking at family history of substance misuse, personal history of substance misuse, age, understanding that the younger population is at more risk, history of pre-adolescent sexual abuse, which I'll get to, any sort of psychological disease like depression, schizophrenia, OCD, ADHD, bipolar disorder also is included there. I do want to talk a little bit about this history of pre-adolescent sexual abuse. You'll notice here that males have a score of 0, which is not a typo. They actually do receive a score of 0. And to be honest, I'm not exactly sure why. We know that any sort of sexual abuse for anybody, whether they're male or female, has a really big impact on them later in life. And so I would think that that would place males at a higher risk of developing opioid use disorder or high risk opioid behaviors in the future, but there we go. But it's not included in the score for some reason. And when I'm administering this risk assessment tool, I actually don't ask specifically about pre-adolescent sexual abuse. I really just ask about any sort of trauma, whether the person's had any sort of trauma in their lives, because it goes back to the ACEs, the adverse childhood experiences. Any of those place patients at greater risk for developing opioid use disorder. So I want to be a little bit more comprehensive than just narrowing it down to sexual abuse. And as a reminder here, the purpose of the ORT score is to just not to be able to say, no, we're not going to, you're high risk, I'm not going to prescribe opioids to you. It's really to identify those people who are at high risk, set a level of clinical monitoring that is appropriate for that risk level, and make sure patients just understand that they're at elevated risk. I think a lot of people don't know that they are potentially at elevated risk, and they might want to be aware of that so that they can be conscientious and make informed decisions about what medicines they do or do not want to take. It also allows you to say, if you are starting to feel that these medicines are not, you're not taking these medicines for the appropriate reason, I want you to come to me so that we can come up with a plan. You're not alone in this. I don't want you to feel ashamed. We're in this together, and I will help you along the way. So it just kind of levels the playing field, lets everybody know how you're gonna approach the treatment with opioids moving forward. And then finally, the SBIRT, or screening, brief intervention, and referral to treatment. This is used a lot in psychiatry clinics, especially with regards to addiction medicine. And so this just allows us to identify and try to prevent problematic use and abuse. It involves screening, using some of those assessment tools to screen patients, provide a brief intervention, engaging with the patients in a discussion about risky use, behaviors that are concerning, and then if necessary, referring patients to treatment. And unfortunately, I think we're experiencing this all over the country, but particularly in Tennessee and in East Tennessee, we just don't have enough treatment options for these patients. And so even if we want to refer them to treatment, sometimes we're stuck not knowing what to do because we just don't have the amount of support for treatment programs that we could use. So next, clinical vignette. Mrs. V comes to your walk-in urgent care clinic reporting that she ran out of her pain pills yesterday. And she reports that she was prescribed oxycodone, extended release, 20 milligrams 3 times a day, total of 90 pills dispensed. And that was 2 weeks ago. She underwent an L4, L5 laminectomy 18 months ago and is continuing to wear a back brace. She's traveling to Florida in the morning. Her UDS is positive for hydromorphone. She reports that she ran out of her medicines because she needed higher doses to control her pain. She is frail, diaphoretic, and complains of diarrhea and is easily agitated. So a few red flag symptoms here. Well, she ran out of her medicines early. So if you look back here, she was prescribed 90 pills 2 weeks ago. And if she were taking them 3 times a day as prescribed, she would have only used 42 pills at this point. So she should have a lot left over that would get her through her trip to Florida. So she's clearly misusing them, taking more than prescribed. She's complaining of what has been termed pseudo addiction. I think this is a term that was coined by the pharmaceutical company. If a patient is taking an opioid but is complaining of uncontrolled pain, it must mean that you are not prescribing a high enough dose. So you need to increase their dose. This was the pharmaceutical company way of telling people that they should prescribe more opioids. Unfortunately, this is not actually the case, that potentially opioids are not the right medication for this patient, or maybe this opioid is not the right medication for this patient. And so pseudo addiction is not a valid diagnosis. Looking at her urine drug screen, she was taking oxycodone, but her urine drug screen was positive for hydrocodone. She is not prescribed hydrocodone, so there's a problem there. And then she is experiencing signs of early withdrawal. So she's run out of her pills early and now is starting to experience those withdrawal symptoms. So thinking about looking at urine drug screens, if you ever have concerns, you can easily Google this information and find out what the common metabolites of drugs are. Codeine is metabolized to morphine. Obviously, there's some variable metabolism there. Some people are rapid metabolizers, others are not really metabolizers of codeine. Morphine gets metabolized into morphine 3 and morphine 6 glucuronide, as well as hydromorphone at low levels. Hydrocodone metabolized into norhydrocodone and hydromorphone. Hydromorphone gets metabolized into hydromorphone 3 glucuronide. Oxycodone gets metabolized into noroxycodone and oxymorphone, which is also brand named Opana. And then there's heroin that gets metabolized to morphine and 6-monoacetylmorphine. One thing to know is that if you are providing if you're doing point of care urine drug screens, there can be false positives. And so if you have a positive test that you're not expecting, or the patient swears up and down that they didn't use this other substance that's showing up in their urine, you can always send it for confirmation testing, and they'll run mass spectrometry on it and tell you exactly what is in the urine and at what quantities. So that's a good way to preserve your relationship with your patient if they swear up and down that they are only taking things as prescribed. It's also a good way of just confirming if they are engaging in behaviors that they shouldn't, that you've confirmed that in fact they have been misusing substances, and that just gives you a little bit more data to be able to say, now is the time that we're going to taper these medications. I hope that you are all familiar with the Tennessee Controlled Substance Monitoring Database, or the CSMD. This is where you can go to check whether or not, check the prescriptions that a patient has received. You just need a DEA number to register for it. And it's a website that everybody should be familiar with and use very frequently. So who's required to check the CSMD? Well, you're required to check it before prescribing an opioid, a benzo, or a scheduled 2 amphetamine, if it is a new episode of treatment, and then again every 6 months if you're continuing to refill these medicines. You're also required to check it if you change the strength or the frequency of the drug. And then, of course, if you have any concerns about the patient's behavior, whether they're doctor shopping, misusing, going to other people, going to the ER frequently, or diverting their medicine, then you want to check it as well. If you're a busy practitioner and you prescribe a lot of opioids and don't feel like you have time to check the CSMD all the time, you can also designate a healthcare another person to check it on your behalf. So somebody like a nurse or an NP or PA can check it on your behalf. It can save you some time. What are the exceptions to checking the CSMD? So you're not required to check the CSMD if the patient is receiving hospice care, if the controlled substance, the quantity prescribed does not exceed the amount that is considered adequate for a single 3-day treatment period and does not allow a refill. So if you're sticking to the 3 days with no refills, you don't have to check the CSMD. And then if you are basically prescribing and the medicine is going to be directly dispensed at a residential treatment facility or nursing home, then you don't have to check it then. It's a good practice to regularly check the CSMD, not only like as required, but just regularly to make sure You understand where the patient is in their number of morphine milliequivalents, whether they're getting medicines from other people. I think it's valuable if you prescribe for patients chronically, you can see whether they've stayed at that dose or whether you've gradually escalated over time. Sometimes we forget if we're continuing to escalate people. And so it can be helpful just to keep things in check, make sure you're not contributing to increased use or increased risk for side effects for patients. Also want to check when, if you're a supervising physician and you have supervisees prescribing under your supervision, and that will allow you to make sure that that supervisee is kind of prescribing according to your clinical judgment as well, whether you think it's appropriate or not. And then finally, you should query your own CSMD data and look for any sort of errors or aberrant behavior, because you want to make sure that somebody hasn't taken your DEA registration number and is using it to prescribe under your name inappropriately. So we are going to turn now to the opioid prescribing laws, which are the Tennessee Together laws, which gives some good guidance about how to prescribe opioids responsibly. So like we said a few times, if you're going to prescribe up to 3 days of an opioid, or 3 days of an opioid and up to 180 morphine equivalents, there aren't really any requirements for that prescription. You don't have to check the CSMD, but it's probably a good idea to. You probably should perform an evaluation of the patient and document it. And then I think it's always good practice to obtain an informed consent, just so that the patient knows the risks associated with opioid use, but really no hard and fast requirements for 3 days of a prescription. Our requirements start kicking in with prescriptions up to 10 days and 500 morphine milliequivalents. So in this case, you are required to check the CSMD. You must conduct an evaluation of the patient and document that. You must obtain informed consent, and then you must document an ICD-10 code on the chart and in the prescription. If you don't, the pharmacy will call you and ask you for one. But you don't have to discuss the risks and the benefits of receiving opioids versus not. And there's no other additional information that you have to put on the prescription. When it comes to prescriptions of longer duration, however, up to 30 days, or 1,200 morphine equivalents, you do have to document everything, check the CSMD, obtain conformed consent, have your ICD-10 code on the prescription and in the chart. You do have to document that you considered other alternatives, so more conservative treatment like multimodal therapy, physical therapy, et cetera, and explain why that opioid prescription and the risk of uncontrolled pain without it is greater than the risk of developing a substance use disorder or having an overdose event. And then if you're prescribing it for surgical reasons, when you're writing your note to the pharmacy, you just indicate that the indication is surgery. Similarly, if you're prescribing it for medical reasons, you write on the prescription medical necessity. And then, just to go to informed consent. So you have to obtain an informed consent for any prescription over 3 days. And then informed consent involves sufficiently explaining to the patient information about opioids that will allow them to make an informed decision about whether or not they want to take these and assume the risks associated with opioids. And so exactly what this entails: risks, the potential side effects related to opioids, so things like nausea, constipation, respiratory depression, somnolence, confusion, the risk of dependence, tolerance, and addiction, what to expect when taking it. So it may make you feel a certain way. If you don't like the way it makes you feel, you can stop it. We expect it to help your pain, not necessarily take your pain all the way away. How they should be used: they should be used as necessary, not just necessarily around the clock. And then describe some characteristics of opioids, including the risks of, like we talked about, dependency, addiction, misuse, and diversion. Discuss reasonable alternatives with the patient and why you've either exhausted those or haven't chosen those. always offer the patient the opportunity to ask questions and have a good discussion about concerns that the patient might have or their reservations. And then finally, if the patient is of childbearing age, you want to provide information about the risks of opioids on a fetus, neonatal abstinence syndrome, and then recommend that they have a birth control plan in place. Getting back to the Tennessee Together laws, there are several exempt conditions where you don't have to do all the things that are required on the previous slides, like check CSMD, document an exam, put an ICD-10 code, et cetera, et cetera. And those include patients who are receiving opioids for sickle cell disease, patients treated by a pain management specialist, treated for opioid use disorder with either buprenorphine or methadone, patients who have active cancer, palliative, or who are being cared for by palliative care or hospice specialists, those medications that are being administered directly to patients at a licensed healthcare facility, or if the patient has been treated for greater than 90 days in the past year. So these patients and situations are exempt from like the timeline, so you can prescribe more than 10 days, more than 30 days, et cetera. But it's still a really good idea to check the CSMD and document your exam and write an ICD-10 code on there. So we've talked a lot about the laws and the risks associated with opioids. And so when is it okay to prescribe opioids? So in general, opioids for chronic pain are not a really good idea, but there are times when opioids are indicated. And I have 5 categories here. There might be more. Some of these are contained under the exempt categories for the opioid prescribing laws: palliative care, pain from active cancer, patients suffering from opioid use disorder who are receiving treatment. Acute pathology or acute pain is certainly a reason to receive opioids. So if you're having surgery or if you have an acute injury, we certainly want to treat people's pain appropriately. So opioids are indicated in those instances. And then finally, if you have tried all the multimodals, you've tried the adjunct therapies and nothing has worked, or the patient has allergies to all the other alternatives, or you've reached your point of using those medicines and you're still looking for more functional improvement, then that might be the time to consider opioids. So like I said just a second ago, opioids for chronic pain are not necessarily a great idea. There are several reasons for this. This picture here comes from an article by Jane Ballantyne in 2003, who really was one of the first people to blow the whistle on opioids for chronic pain and say that they're not a very good idea. One of the reasons they're not a good idea is because of the idea of pharmacologic tolerance. So when you have chronic pain, you're probably going to have chronic pain for a really long time, hence the name chronic. And so that pain is not necessarily going to go away. We're going to try to help it, but it's not the pathology involved is not going to necessarily go away. And the problem with tolerance is that the patient's going to need higher and higher doses of that medicine over time to achieve the same analgesic benefit. So you've got a chronic condition and you've got a medicine to which people develop tolerance. And so it ends up being a path to nowhere. You're just going to have to increase the dose over time to continue achieving analgesic benefit for these patients. The problem with that is that patients age over time, they develop chronic medical conditions. And so medications that were once benign to this patient end up being relatively harmful for them in the future. So patients develop COPD, then develop respiratory depression. That can lead to a whole host of bad things, or they develop renal dysfunction, and the metabolites to these medications that we were previously able to get rid of through the urologic system, they're no longer able to get rid of. They build up metabolites, they develop altered mental status, et cetera. They end up in the hospital, and those problems cannot just necessarily be attributed directly to the opioid, but the opioids certainly play a role in kind of the complications associated with chronic medical conditions. So that's one of the reasons that we kind of shy away from chronic opioids or opioids for chronic pain. The other thing to think about is the fact that opioids can cause what we call opioid-induced hyperalgesia, or OIH. So what we have found with patients is that the longer that they take the opioids, and the higher the dose, the more sensitive their body becomes to pain overall. And so there are neuroplastic changes that occur in the central nervous system that change the way the body's pain signals are relayed. And ultimately, opioids make people more sensitive to pain. So things that previously weren't painful end up causing a lot of pain for patients. And if you try to escalate the dose of opioid to help with that pain, unfortunately, it just makes the pain worse. So the appropriate response there and the appropriate treatment is to actually decrease the dose of the opioid over time. And that's really what makes the patient better. So I see this all the time in the hospital for patients who have been on opioids. They're laying in the bed, everything hurts. And they're asking to increase their dose of opioid. And I have to say, I actually think the opioids are hurting you here. I think you'd feel better if you were able to reduce your dose. Some people buy in, some people not, but ultimately the opioids end up causing more harm than good for these patients. Other things to keep in mind is that the chronic opioid use can interfere with the various endocrine functions. And so there are two main hormonal systems at play here. So opioids have been shown to interfere with the hypothalamic pituitary adrenal axis, and then the hypothalamic pituitary gonadal axis. So you may be aware that patients who use opioids chronically are at risk of developing things like osteoporosis or low testosterone, causes sexual dysfunction, et cetera. So that's a good reason to not prescribe opioids long-term for patients. And then finally, opioids are implicated in immune changes as well. So mu-opioid receptors have been found on immune cells in both the adaptive and the immune system, and likely influences changes in those systems there. This can be really important for people who have cancer. Obviously, if a patient has pain from active cancer, we really want to take good care of them and treat their pain. But as soon as that pain is controlled, or if their cancer goes into remission, we really want to taper off those opioids, because we do not want our opioid prescribing to influence the potential reoccurrence of a cancer. And this is actually something we think about all the time in intraoperatively. So just to give you an example, with breast cancer patients, where I trained at Duke, I did my residency at Duke. And for patients who were getting mastectomies for breast cancer, we actually didn't use any opioid intraoperatively because of the fear that it was going to interfere with our natural killer cells and put people at risk for either spread of cancer or recurrence of cancer. So it has real implications for patients' long-term health. Switching gears here, we're going to talk a little bit about the chronic pain guidelines. These guidelines are very extensive, and they're available to you at the Tennessee Department of Health website. One thing I want you to be aware of is that these are not written for pain physicians. They are specifically written for primary care doctors to give primary care physicians, family medicine doctors, anybody else who's thinking about prescribing opioids for chronic pain, a lot of guidance. So there's everything you want to know about prescribing opioids for chronic pain are contained in these guidelines. You can see here, this is just the outline or the index here. You've got 3 sections, and then there's a lot of appendices to answer all the questions that you might have. So we're going to go through these just very briefly. Section 1 is key principles to initiating opioid therapy. And then the prior to initiating opioid therapy, section 2 is about initiating opioid therapy. And then section 3 is about ongoing management of opioid therapy for chronic non-malignant pain. There's a lot here on this slide. This basically summarizes the first section of the guidelines. We've gone over quite a bit of this already. Just because somebody has been taking opioids for a long time doesn't mean that they just need to be continued on them. We always want to be conscientious of whether or not we are achieving our functional goals. If we're not achieving our functional goals, maybe it is time to either switch medication, switch to a different opioid, so we're not just increasing our dose, or try alternatives, be they multimodal therapy or other interventions. Always want to perform a thorough evaluation, document any comorbidities, document your risk assessment. If you are taking care of somebody of childbearing age, have a contraception plan in place, check your CSMD, and remember that your primary goal is to improve function. So we're not treating pain scores here. Pain scores, again, were really promoted by our pharmaceutical colleagues to try to get everybody to prescribe opioids. And pain scores are just incredibly subjective, so have very little, provide us little information. And so our main goal is to focus on function. Set some goals. What are your goals? If we're achieving those goals, great, we can continue our medicine. If not, we need to think about a different option. So when you decide to prescribe opioids for somebody with chronic pain, it really is meant to be a trial. And if you're not achieving those goals, then you need to consider alternatives. Just to draw your attention to the top right corner of the black box, telemedicine is not an appropriate venue for prescribing opioids for chronic pain. During the COVID pandemic, this was acceptable. We were able to prescribe opioids for chronic pain or for any reason via telehealth, but that has expired, and now it is not legal anymore to prescribe opioids for chronic pain or for any other condition via telehealth. Section 2 is about initiating opioid therapy. So just to remind you that the risk of overdose starts when you get above 40 morphine milliequivalents a day, and that risk increases greatly at between 80 and 100 morphine equivalents. So you really always want to start at the lowest dose, use the lowest dose for the shortest amount of time possible. And like we said, it's a therapeutic trial. So if you're not achieving their goals, you want to discontinue them. The risk of unintentional overdose death increases 12 times with concurrent use of benzodiazepines and opioids. And so those two in combination can be really dangerous. I like to avoid benzodiazepines because I'm not a psychiatrist. I like to have those reserved for my psychiatry colleagues. There are certainly good reasons to prescribe benzodiazepines, but if benzos are used and the patient is using over 120 morphine equivalents per day, they probably need to be referred to a mental health specialist and potentially a pain doctor to evaluate the necessity and the appropriateness of those doses. You always want to have informed consent and have the patient sign a treatment agreement, maybe renew that annually. I'm not sure if that's a law or not, but we have them in our clinic, renew that treatment agreement annually. And then of course, always monitoring for signs of diversion by looking at the CSMD and checking urine drug screens. For ongoing opioid therapy, the CSMD is just so important. You're going to want to ensure that the patient is receiving medicines only from a single provider, getting them only from a single pharmacy, using the lowest effective dose possible. You're documenting your 5As, which we'll go over in a little bit. And then, like I said, if they're using more than 120 morphine equivalents a day, referring them to a pain physician just to say whether or not that patient is a good candidate for opioids, be able to say, I think you could try some alternatives, some multimodals. It looks like your dose has increased over time. Here's an opioid rotation that you can try that will actually reduce your morphine equivalents. You may get some better bang for your buck. And then of course, discontinuing your medicines if the risks outweigh the benefits. Again, regarding women's health, always wanting to make sure women are aware of the risks associated with chronic opioid use, especially if they get pregnant. So ideally having a contraception plan in place and documented. However, if the patient does become pregnant while they are using opioids, you want to refer them to an obstetrician, but also it's safe to reduce that dose, if not discontinue that dose during pregnancy. If the patient has developed opioid use disorder and you're concerned that discontinuing those opioids may lead them to use illicit substances, then it is safe to put them on methadone or buprenorphine during their pregnancy. I would do that under the supervision of an OB because it does require titration of those medicines. And it's a good idea to obtain urine pregnancy tests before initiating opioids and then at follow-up visits. I'm not going to go over this. This is more about the risks associated with opioids and pregnancy. And then to draw your attention to the Narcan law, which was implemented in July 1st of this year. So this law essentially says that if you must prescribe a naloxone prescription, you must prescribe naloxone to a patient if you are prescribing more than 3 days of an opioid and You are also concurrently prescribing a benzo. So you have to be the prescriber of both the benzo and the opioid. Or if you're prescribing more than a 3-day supply and the patient is at increased risk of overdose. So whether they've had a history of substance use disorder, whether they've had an unintentional overdose in the past or an intentional overdose, or whether they've been on high dose opioids in the past and have titrated down and are no longer tolerant to high doses. So those are kind of the requirements for naloxone prescribing. So as a chronic pain doctor, when we're thinking about how to treat people's pain, we really try to think about tailoring the treatment to the type of pain that the patient has. And so there are different ways of categorizing pain. Acute and chronic is the easiest. Like I said, acute pain is certainly an indication for prescribing opioids. I would recommend always optimizing your multimodal treatments as well. But just to distinguish acute pain from chronic pain. So acute pain is pain that lasts less than 3 months. It's associated with tissue damage. It does confer a biological like survival advantage. Our bodies need to know that they're hurt, so we'll take care of them and not hurt ourselves further. Usually it's short-lived and gets better over time, and that's why it only lasts a few weeks and less than 3 months. Chronic pain is essentially pathologic pain. So it's pain that outlasts the time of healing caused by whatever injury. There's no biological purpose that is served by chronic pain. It really just serves to make people depressed and anxious, and it can be a lot harder to treat. Lots of other things that figure into the experience of chronic pain: psychological issues, genetics, biological issues. It gets back to that biopsychosocial model. So another way to characterize pain or to categorize it is based on the type of pain. So 3 categories that we have: nociceptive, neuropathic, and I prefer the term nociplastic rather than psychogenic. So nociceptive pain is pain due to tissue damage, be it somatic from the bones or soft tissues, or be it visceral pain from damage to any of the organs. Somatic pain is usually easier to identify both on location and based on quality. Usually a sharp stabbing, potentially dull. Pain from the organs or visceral pain is usually a little bit harder for patients to identify the exact location. It's dull, or they're not able to really describe the type of pain that it is. Neuropathic pain is due to nerve damage itself. That can be both in the central nervous system or in the peripheral nervous system. Just some examples of central nervous pain related to central nervous system disorders are things like post-stroke pain, pain related to spinal cord injuries, pain related to MS or to Parkinson's disease. Peripheral nerve damage that causes pain includes things like postherpetic neuralgia, diabetes, trigeminal neuralgia, complex regional pain syndrome type 2. And then finally, people usually describe that as like a burning pain. It's often associated with paresthesias or allodynia or tingling sensations, or just reduced sensation overall. And then our final category is nociplastic pain, which is kind of got a lot of psychological overlay here. So things like fibromyalgia, IBS, some people put migraine headaches into that category. These are chronic pain syndromes where there's no pathologic cause. So no reason for the pain can be identified either based on radiologic imaging or based on lab studies. So we can't identify the cause, but patients have real pain and we really need to honor that pain. And I think ultimately there's just a lot of changes that occur in the central nervous system that we don't understand yet. At some point we may be able to better categorize these types of pain, but right now they get lumped into this other category. These often do have associations with psychological conditions, things like depression, anxiety, stress, catastrophizing, fear. And there can be a lot of overlap with other somatic complaints, things like Ehlers-Danlos syndrome. We see a lot of comorbidity with Ehlers-Danlos syndrome, POTS, mast cell activation syndrome, just a lot of kind of somatic complaints, like the body is just somehow exaggerated its response to a lot of different stimuli. So in terms of medications that we can use to treat people, Tylenol is a great one. The FDA recommends no more than 3 grams a day. If the patient has chronic liver disease and is not drinking alcohol and has no other infectious diseases that might influence the liver, you can still prescribe up to 2 grams a day. If they have chronic liver disease and are drinking alcohol or have something like hepatitis B or hepatitis C, I'd steer clear of acetaminophen due to the risk of hepatotoxicity. NSAIDs are great anti-inflammatories. Pain is ultimately related to inflammation, both in the peripheral nervous system and then the central nervous system. So trying to kind of calm down that nervous system is always a good idea. There are lots of side effects that we have to think about when it comes to NSAIDs, and this really limits our treatment options for patients with a lot of medical comorbidities. So risks associated with NSAID use in the GI system, it can lead to GI bleeding and peptic ulcers. In the kidneys or the renal system, it can reduce NSAIDs can reduce GFR. They can increase sodium and water retention, which leads to hypertension, or in patients with heart failure, put them at risk of a heart failure exacerbation. And then in the cardiovascular system, the effects really depend on the COX-1 versus COX-2 inhibition and the balance between those two. So can either lead to bleeding or clotting. This is a little scale that shows where the different NSAIDs fall on the COX-1 versus COX-2 inhibition. So you've got ketorolac, which, excuse the spelling, it's misspelled here on the left, which is very COX-1 selective. It's an amazing drug, but COX-1 selective. For that reason, it has a black box warning for GI bleeding. So you're not supposed to use it for more than 5 days in a row due to the risk of GI bleeding. On the other end of the spectrum is celecoxib or Celebrex, which is not going to interfere with platelet dysfunction or platelet function. It's not going to cause GI bleeding. In the middle, you've got naproxen, which is thought to have the lowest cardiac risk. It's kind of that COX-1 and COX-2 balance. And you can kind of see where the other ones fall as well. So NSAIDs are great anti-inflammatories. Unfortunately, we're limited by our side effects. We often use antidepressants to help with pain control. I think you kill 2 birds with 1 stone here, because chronic pain is often associated with depression. It's this vicious cycle, which came first, the chronic pain or the depression. They just unfortunately feed off of each other very frequently. So the antidepressants can help both the pain and the psychological comorbidity associated with it. And they act by increasing serotonin and norepinephrine in the descending pathways. So we have the ascending pathways, which tell our brain that we have pain, and then we have the descending pathways that try to modulate pain and reduce our experience of pain. So we're trying to increase the descending inhibition. You've got TCAs, which are not quite as used quite as frequently for psychological purposes. Now we use them a lot for pain. Amitriptyline, nortriptyline, and desipramine are kind of the 3 common ones. Amitriptyline being an earlier generation, so it has more side effects than the other 2. We do have to watch out for the anticholinergic side effects, and those things include like sedation, dry mouth, blurred vision, and urinary retention. And it's these, the anticholinergic side effects that make me really steer away from these in older adults. I generally don't prescribe TCAs to people above about 55. I might push 60 with nortriptyline or desipramine. But certainly older men, I'm going to shy away from this just due to the risk of urinary retention with concurrent BPH. Other things you have to worry about are arrhythmias and hepatotoxicity. So avoiding in people who do have a history of arrhythmias or any sort of liver dysfunction. The SNRIs are really great drugs as well, increasing both serotonin and norepinephrine. Duloxetine, milnacipran, and venlafaxine are the ones we use most often. I will say that between the SNRIs and the TCAs, I think of them both as being great drugs. TCAs, if a patient's pain is primarily neuropathic, and I've tried like gabapentin or Lyrica, which we'll get to in a minute, I'm going to go with a TCA if it's primarily neuropathic. If it's more myofascial, seems to be musculoskeletal, but may have a neuropathic component, I'm going to go with an SNRI. But then when it comes to older adults, I steer away from the TCAs. Things to think about with both of these categories is that they do have the risk of sedation, sexual dysfunction, weight gain. And then the black box warning for these medications with young adults is that they do have the potential to increase suicidal thinking. And so if patients have that adverse effect, want to stop it immediately and seek treatment to make sure we keep those patients safe. And then keep in mind that because these medications are also used for people with psychological illness. If they are prescribed another a serotonergic agent, there's risk of developing serotonin syndrome. So we just need to be aware of that. And then the other thing to keep in mind is that those with bipolar disorder, starting an SNRI or TCA has the potential to send them into a manic episode, and we want to avoid that as well. So just be conscientious of that.
Yes.
It's a good. So the question for those of you on Zoom is that if a patient who has chronic pain is already on a serotonergic agent, something like Zoloft, would you directly switch over to like an SNRI, or would you titrate down and then switch over? And to be completely honest, I Google it every time because of the half-lives of these drugs varies so much that I can't keep up with it. And so to be safe, I just Google like half-life, or even now there are lots of good resources for if you're switching from one to another, how much time do you need to wait between switching? So Google is your best friend in that respect. I think your question brought up something else, but I can't remember what it is. If I think about it, I will come back to it. But great question. I don't automatically switch over because I'm scared about inducing serotonin syndrome in people. Oh, I remember what I was going to say. Is if a patient is already on a serotonergic agent at kind of a high dose that makes me a little nervous, I will actually ask their, if they're seeing a psychiatrist, I'll actually ask the psychiatrist before I start one of these other medicines, just to make sure that psychiatrist thinks it's safe, and that I'm not going to be giving too much of a serotonergic agent. Also, just to make sure we're all on the same page about what our goals are, and make sure we're all being vigilant for side effects in these patients. Because ultimately our number one goal is to not do any harm to them. So our anticonvulsant medications are our membrane stabilizers, our gabapentinoids, are sometimes they're referred to. These are great for neuropathic pain. So here on the left-hand side of the screen, you've got your voltage-gated sodium channel blockers, carbamazepine, oxcarbazepine, and topiramate or Topamax. These are kind of your second line agents for neuropathic pain. These are not ones I jump to. Actually, they may be third line because I'd go to a TCA or an SNRI before I'd go to these, but they're great for certain conditions, certainly like trigeminal neuralgia. Carbamazepine is really good for that. But you have to worry about some lab abnormalities here. So you need to be conscientious about checking labs if you are prescribing these medications chronically for patients, because they can cause agranulocytosis, things like that. But turning to pregabalin and gabapentin, these are sodium channel blockers, which are probably the number one anti-neuropathic medications. So gabapentin was developed first, so it tends to be cheaper medication and therefore the one we start first. Pregabalin was brand name only until just a few years ago, and now it is generic, but it does still tend to be a little bit more expensive. Sometimes the insurance companies will make a person fail gabapentin before you can start Lyrica. Sorry, pregabalin and Lyrica, synonymous. So a few things to know about these drugs. So gabapentin, as you increase the dose, the bioavailability decreases. So you may increase it over time and the patient is experiencing pain relief, but then their pain relief kind of slows down, but they develop side effects to it. And that happens pretty regularly. Lyrica, on the other hand, as you increase the dose, the bioavailability actually increases. So there's a potential that you can get more bang for your buck with pregabalin. What this means in terms of treating patients with chronic pain is if you prescribe gabapentin and get to a certain dose, but the patient starts getting side effects, you may be able to switch over to Lyrica and be able to provide more analgesia without the same degree of side effects. So it's always worth trying. And so if you get to a point with gabapentin, you're like, it's not, that increase didn't really help my pain. I might be starting to feel a little fuzzy headed. Switch over to Lyrica. You might get more analgesia with fewer side effects. And to make that switch, unlike with switching between different antidepressants, you don't have to titrate down on the gabapentin before titrating up on the Lyrica. You can make a direct switch. And the way that you do that is by taking the ratio of, or the percentage of the maximum dose, and then converting right to the percentage of the maximum dose of the other. So if the patient is on the half max dose of gabapentin, you transition them directly to the half max dose of Lyrica. 1/3 the maximum dose goes to 1/3 the maximum dose of the other medication. No need to titrate down or titrate up. The switch one day to the next. The other thing to remember about these medications is that you can induce withdrawal if they're abruptly stopped. So you never want to abruptly stop these medications. You always want to titrate down on them, even if the patient is having side effects. So patients can have withdrawal seizures associated with these medicines. So always titrate down over a period of several weeks, depending on what their dose is. Any questions about those two? Okay. There are some topical medications that can be helpful for pain. Capsaicin is one of them. It is derived from chili peppers. It depletes substance P, which is a huge inflammatory mediator at the nociceptive transmission. Problem with capsaicin is that it burns just like chili peppers burn. So patients need to be warned that it may be a little uncomfortable. Once that burning goes away, they experience relief. Some people just don't like that period of burning and so don't want capsaicin. So always warn them about what they might experience. Don't prescribe too big of a tube because you don't want them just having it hanging around. Local anesthetics, things like lidocaine that comes in a gel form or a cream form, also in patch form. You can buy the patches over the counter. They're 4% lidocaine. The prescribed ones are often 5% lidocaine, so 5 versus 4. Patients tell me that they're a lot more expensive to get the ones that are prescribed. And so I often tell people, just buy it over the counter. It's 4% versus 5, but it's a lot cheaper. The other topical medication that's not listed here is diclofenac gel or Voltaren gel. It is an anti-inflammatory. It's really great for people who have comorbid medical conditions that limits the number of NSAIDs or amount of NSAIDs that a patient can take. So with the gel form of diclofenac, there's very little systemic absorption, but it can be really helpful for patients who have inflammatory pain, often in the joints. So it penetrates only a few centimeters into the skin. So considering our population here in Tennessee, that might not necessarily be effective for everybody, but if you can palpate the joint, it's most likely going to help, and it can be a really great anti-inflammatory for people, especially if their use of NSAIDs is limited. Other things that we can do to help treat pain, we always want to keep in mind these non-pharmacologic things: ice, heat, gentle movement, including yoga and Tai Chi, biofeedback, acupuncture, cognitive behavioral therapy, mindful-based stress reduction, etc. I know that at least we have an integrative medicine center that offers a lot of these. I'm not exactly sure what is offered around here, but then people, there are pain psychologists also around that do a lot of these treatment options as well, which are probably equally effective, if not more effective than the medication options. Pain clinics can offer interventional procedures for pain management as well. Things like trigger point injections, tendon, bursa, and intra-articular injections, peripheral nerve blocks, sympathetic blocks, interlaminar and transforaminal epidural injections, radiofrequency ablations for low back pain, spinal cord stimulators, and then a myriad of other things. Just as a summary slide here, all of the treatment options for pain, we've got our pharmacologic treatments that are both non-opioid and opioids, our non-pharmacologic treatments, which are the complementary and alternative treatments, and then our interventional treatments. So lots of things that we can try to help with patients' pain. Ultimately, one thing is not necessarily going to be the the silver bullet. It often requires a combination of all of these things to improve patients' pain. I will say, before I forget, that one of the doctors at the previous session today, who's an orthopedic surgeon, he said that he's found a ton of benefit in setting expectations for his patients. And I think that's actually one of the most important things that we can do to help manage pain expectations, especially when it comes to acute pain. If you're a surgeon, telling your patient to expect pain is a really great idea. We have some good medicines, but they're not going to take the pain away. Our body's response to insult is to have pain. It's protective for us. We can expect it. This is the course that we expect. We expect it to last 2 to 3 days. And after that, it's going to get better over time. You will expect pain, and this is going to how we're going to be treating it. When you're doing your documentation, you always want to document the 5 A's. So analgesia, activities of daily living, affect, adverse reactions, and whether or not there have been any aberrant behaviors. And then what is misprescribing? Well, we defined it a little bit earlier, but it's prescribing when quantities or frequency inappropriate for the complaint. Things like just giving large quantities or frequently escalating the dose, using more than one short-acting opioid medication, prescribing for things that are not necessarily good reasons to prescribe, prescribing to family members, or prescribing to somebody with known and untreated alcohol or substance use disorder. Here, I do want to say that if a patient is being treated for opioid use disorder and like with methadone or buprenorphine, and they have an acute issue, such as they go to surgery or they have a broken bone, it's perfectly appropriate in those instances to treat them with short-acting opioids. You may want to consult a pain doctor, but we certainly wouldn't want to deny somebody treatment of an acute issue simply because they have a use disorder. Some categories of misprescribing, they're all D's. So if you like alliteration, this is for you. And I'm not going to read through all of them, but simply not keeping up with the latest in the practice standards of care, prescribing for financial gain, just really not using your best judgment to prescribe to patients. And then various times when you should suspect drug-seeking patient behavior in patients. So all of these categories, if the patient's very dramatic and compelling, but they have a very vague pain complaint, if they are pressuring you for increased doses, you are providing a prescription, but their urine drug screen is negative for the drug of that you're prescribing them. If their symptoms contradict clinical observation, so often what I've seen is patients will come into the pain clinic and ask for opioids for their low back pain or whatnot. And they'll say like, I can't walk. I can't stand up straight to walk. And then you go ask the nurse who escorted them to their room, and they're like, no, they were fine walking in. Like they looked perfectly fine. Patients asking for a drug by name, having no interest in the diagnosis, or saying that they're not willing to take any other treatment options other than the opioids, are good red flags. Other things, if they say they're allergic to NSAIDs or any other multimodal for that matter, a lot of times these patients will accumulate a list of allergies. If the patient tends to know a little too much about pharmacology and various drugs, if they're making veiled threats, one of the ones that is common that I see is patients who say, well, I need you to prescribe this drug for me. If you don't prescribe it, I'm just going to go buy it on the street. Well, that's not really helpful to me. And I can't control what you do outside of my clinic, but I don't think it's responsible to prescribe this medicine for you. And I don't think buying it off the street is a very good idea either. Patient can be very flattering. They say that their primary doctor is out of town, like going to an urgent care and saying that their primary doctor is out of town, they need a refill. If the patient travels long distances to get to you, which can be a challenge here in Chattanooga. I know that y'all are so close to Georgia that people probably do travel legitimately from Georgia to get here. And so you have to use your judgment as to whether or not you think that is reasonable. We try to only prescribe to patient at Vanderbilt. We try to prescribe only to patients in Tennessee who are residents in Tennessee, but Kentucky is only an hour north, and healthcare directly an hour north is, they might have to travel 2 hours to an equally good healthcare facility in Kentucky. And so really have to just pay close attention and make good decisions there about what you think is appropriate and what is not appropriate. And then something I see pretty regularly is that they say their primary doctor just retired. Unfortunately, that's not a really great reason. If the patient's doctor did retire, they should have had some good warning to find another doctor. So just a few red flag symptoms there. Okay, we're finishing up here. This is our last clinical vignette. Dr. Calcium sees her PCP for recurrent kidney stones. She rates her pain a 7 out of 10 in severity. Her PCP prescribes hydrocodone, Tylenol, 10-325, number 30, and refers her to the urologist. The next morning, the urologic workup shows 2 stones with no urinary obstruction. The patient was not asked about her pain at all and was prescribed hydrocodone and Tylenol, again, 10-325, was given 90 pills this time. The patient was not asked by either office if she was taking any medication for pain, if she wanted any medication for pain, or if she already had pain medicine at home. She goes home with 2 prescriptions of hydrocodone and ends up not taking any of it, but instead taking Tylenol, 1,000 milligrams for her pain, and her pain score drops to a 2. So looking at our red flags here, patient was prescribed hydrocodone twice without actually getting anybody taking a thorough history of her needs, her pain complaint, her needs, and her history. Again, standing orders for opioids, especially those for up to 30 days, are really not a good idea. We really want to be conscientious and good stewards of our opioid prescribing. And then for this patient, over-the-counter medications work just fine for her pain. So she never actually needed to have an opioid prescribed in the first place. And with that, I will wrap it up. And if you have any questions, please don't hesitate to ask them.
There has been a lot of emphasis on
Mhm. Yep.
What are you seeing now? Are we doing just a poor job, or are we shifting now to other substances?
Great. Yep. Good question. So for those of you on Zoom, the question was, has the landscape of opioid use disorder or opioid misuse changed over the last several years? And the answer is yes, very, very much so. So if you look at the data, and I can't give you numbers here, but if you look at the trends in opioid prescribing since the CDC guidelines came out back in 2016, the opioid prescriptions have dropped almost precipitously, like this, very, very down in all categories for every age group and for every duration of prescription. So the number of 30-day prescriptions has decreased. The number of 3-day prescriptions is decreased. Like overall, opioid prescribing is down. The problem is that our rates of overdose death have increased significantly, especially since March 2020, when the the COVID pandemic started. And the reason is that we're doing a better job prescribing, reducing our numbers, but deaths are increasing, and there are several reasons for that. People are using in isolation, so they're buying, people that maybe previously were using prescribed opioids have now turned to the streets. But the problem is that the opioids now on the streets are so very potent that people are just dying in higher numbers than they were previously. So you might be able to live with an opioid use disorder using your pills and be, safe. You have your opioid use disorder, but you're relatively safe from unintentional overdose. Now, if you're buying things off the street, even if you think it is a pill like oxycodone, it's not oxycodone, it's got fentanyl mixed in it. And unfortunately, the batches are not uniform. And so you have absolutely no idea how much fentanyl or what the potency of that fentanyl is. And so even one pill can just kill somebody who previously was taking, opioids in pill form. And so even I think the death rate is a lot, people using illicitly, but even first-time users are dying. And so people who don't actually have an opioid use disorder, they're potentially even just experimenting with drugs for the first time, are dying. And so it's contributing to our overdose rate. So really, opioids are just so much more potent these days. Fentanyl is also mixed into everything else. So marijuana laced with fentanyl, methamphetamines laced with fentanyl, cocaine laced with fentanyl. So even if you think you're using cocaine, you can die from a fentanyl overdose. So yes, the landscape has completely changed in terms of opioids. There is totally different ball game in terms of potency, which is the problem. This is why we're seeing so many more overdose deaths. The other thing that I'm experiencing, the number of patients using methamphetamines is increasing significantly over time, and that's leading to a whole host of other problems too, psychiatric conditions that are placing people in the hospital, violent crimes, substance-induced mood disorders, things like schizophrenia that are related to substance misuse. So all of those things are increasing as well. So we're really not on a good trajectory, to be completely honest. We don't have, like, we have great medications, methadone and buprenorphine for treating opioid use disorder, but when it comes to stimulant use disorder, we have no good treatment options. And so that's actually the thing I encounter the most with my patients. The biggest challenge is, like, everybody in my schedule on Fridays at my opioid use disorder clinic, they're all abstinent. They don't have opioids in their urine, but they all have methamphetamines in their urine, and I don't know what to do about it. And so it's, and then my fear, fortunately, they're taking buprenorphine, which is protective, but my fear is that they're going to get their methamphetamines laced with something else, and that's going to kill them. So it's just a very, very challenging environment right now, and it's super scary. Yeah. So the question is, why would drug dealers put fentanyl in everything? It's a great question. You ask, like, why would you want to kill off your population that is paying you money for things? And the answer that I've gotten from people is that there are always more people to buy, like, because we can, which is a horrible explanation. I don't know. It doesn't make any sense at all that you would want to kill off the people that are spending money and paying you, essentially. But people will always come seeking more and more drugs. If it doesn't kill them, it's so darn good that they're going to want to come back. And I had a patient one time, it just, like, really hit home how powerful addiction is he said to me, he had a friend who used this substance over here from this dealer, and that friend died from an overdose. And he was like, man, that must have been such good stuff. I want to go find that. And so that just shows you how badly people's brains get changed by addiction. And it really enlightened me, like, wow, like, it's so good. I want to experience that high, even if it kills me. And so if it doesn't kill them, they're going to want to go back for more. And I guess that's why, just to give some perspective, but it really doesn't make any sense, unfortunately. Yeah, I don't have a lot of good thoughts, because they're so unregulated at this point that you actually don't know what you're getting at all. You can buy from this drugstore or this CBD store. I have absolutely no idea. There are some stores, like naturopathic stores, that potentially have, you actually know what you're getting when you're buying it. I don't know a lot about it. Some people swear by it, other people not. The research that has been done in California, Mark Wallace does a lot of research into marijuana and THC. His assertion is that CBD doesn't really have much of an effect, especially on pain control. It's the THC component of marijuana that is effective for pain control. And the THC at low quantities, very low quantities, is what's actually helpful for pain. And if you get above those low quantities, it actually is not helpful and actually detrimental, and people don't like it. However, anecdotally, I have had multiple people say that CBD is what really has helped them. One of my colleagues, who is a recovery coach at Vanderbilt, who has opioid use disorder, he's in recovery, he's completely abstinent. He had a herniated disc and had to undergo 2 back-to-back back surgeries. And he said he went to Colorado and got some compounded CBD oil. Who knows if it had THC in it or not. He said it was the best thing for him. And so I tell people, I have no idea. There's not really good evidence because it's not regulated. It may be worth trying if it's your only option, and if it's a better option than opioids, keeping in mind that because it's unregulated, you may have a urine drug screen that shows up positive for THC. So you just have to warn them that if you want to assume that risk, unless you get it from somewhere where it's known to have only CBD and no THC in it. I'm of the thought, like, you might as well try, even if it's a placebo effect. It's probably safer actually than a lot of the other medications we prescribe, even like NSAIDs, if you have a lot of comorbid medical conditions. So, but there's just not good evidence for it. Anything else? Okay, well, I will let you all get back to your afternoons. Thank you all so much. You are welcome.
Okay. Busy up there? Yeah, we're about to relocate our renovation of our old CC here. Although I heard yet. Mark, thank you for your work. That's good. That's a good thing to use your time. Done. Thanks for your work. Oh, you're welcome. Thank you. Yes.